evening, everyone. It's my honor to welcome you to the international webinar Latest Myopia Reviews, Epidemiology, Awareness and Research, organized by United Optometrists Forum in collaboration with ZEISS Vision Care. Myopia is rising rapidly across the Middle East and Africa, and childhood myopia is now one of our greatest eye health challenges. Today, we bring together global experts and regional leaders to share the latest research, insights, and solutions to help us respond effectively. This webinar is officially accredited by Dubai Health Authority with 1.75 CME credits, reflecting its value to our professional growth and practice. Before we begin to the scientific session, I would like to warmly invite Ms. Celine Cambroge, Head of Medical Science Liaison for the Middle East and Africa at ZEISS Vision Care, to say few words. Over to you, Ms. Celine.
Good evening, everyone. I hope you are all doing well. I am very happy to welcome you today and to have this new session. It's not the first time you are getting used to us in our educational program. And you know that when you are dealing with myopia management in your practice, you need to be updated with all new studies, results, technologies, innovations, and so on. I'm very happy tonight to have such a huge panel of professors and experts into myopia management who are going to be able to talk to you about myopia management in the world and in our region, because we know that from one region to another one, the myopia is not evolving the same way. So we need to know what is happening in the rest of the world. How is the situation right now here? And what to do. What is the best tools that we can give to you to slow down this pandemic? So I really would like to thank all of the speakers tonight. It's really an honor for us to have you here, all of you. And I also, of course, would like to thank again UF Association, who has been our big partner for a very long time now. And it is absolutely not the end. We have more surprises in our pocket for you. So please enjoy this webinar. Put all your questions in the chat, and we will have one more time again for sure, very interesting Q&A session at the end of the webinar. Thank you and enjoy.
Thank you, Ms. Celine, for your insightful words and for ZEISS Vision Care's continued commitment towards advancing eye health. It is now time to begin the part we have all been waiting for, our scientific session. To lead us into this exciting journey of knowledge, I am honored to hand over to Mr. Ian James, member of the Advisory Committee of the United Optometrists Forum, who will introduce our first distinguished speaker of the evening. Over to you, Mr. Ian.
Thanks very much, Celine. And on behalf of the United Optometrists Forum of the UAE, I'd like to thank ZEISS for arranging this event, which I'm sure will impart a lot of useful information about myopia and the current thinking on its intervention. Our first speaker is Professor Languis Michaud, who's been working with the University of Montreal for the last 24 years. He is Professor of Primary Eye Care, Cornea and Contact Lens, and he will share his thoughts with us on global insights on key myopia studies. Thanks very much, Celine.
Hello, everybody. My pleasure, and it's an honor to be with you today. Thanks for the invitation to join this webinar about myopia. Myopia is one of my main topic research here at the University of Montreal. And certainly my duty today is to introduce you with the literature review of what was published in the last year and a half, most important articles and what we can summarize from the literature. There are more than 2,000 articles published every year on myopia, so it's not an easy task, but we'll try to go that route together. I have nothing to disclose to the exception that I'm paid by ZEISS to be present today, but any of the content that I will present was influenced by this company. So as I mentioned, I consulted 2,279 articles published in 2024, and I look at those most cited from the first month in 2025. So I read all of these abstracts and I selected I tried to summarize by topic these articles. So let's dig in what was published in 2024. So these are the most cited articles, the 10 most cited articles. That means that they were serve as reference for many other authors in the field. This one got 75 citations over the years, so it's quite rare to have this amount of citations the first year you are published, and it tells a lot about the quality of this work. So it's about the influence of environment and lifestyle on myopia. So we know that the environment we are living in is certainly an important factor to explain why myopia is developing. Those living in urban cities, a closed indoors environment, looking at screens, not exposed to outdoor, not exposed to a wide field of view, not exposed to natural sunlight, are more prone to develop myopia, and their myopia evolve more rapidly. It reminds us that it's not only the eye, not only what we put on the eye, but the quality of the visual signal that influence the eye growth is dictated mostly by the environment we are living in. And certainly that influences the development and progression of myopia. So this article summarized very well how we can improve those environments in order to lower the myopia rate and its progression. So outdoor free space near work is more and more considered as a risk factor for myopia. So the distance of reading and consulting the screens more than the screen themselves is very important, because kids are looking at their tablets and phone at 10 to 15 centimeter, which is way too close compared to what is supposed to be the good Harman distance from the elbow to the tip of the finger, is still highly valuable, and we have to remind parents about that, and patients as well. The surrounding lighting is important as well, and to make pauses every 30 minutes is as important. So 2 minutes every 30 minutes, not the 20/20 rule. 20/20 rule, it doesn't work anymore in such environments. So 20 seconds, looking at 20 feet for every 20 minutes, no, not enough. So you have to make a pause of 2 minutes every 30 minutes in order to relax the visual system and to relieve some stress from the visual symptom. So the second article cited in 2024 is about the prevalence of myopia around the world. Brian Olden many years ago established the fact that by 2050, 50% of the population will be myopic, and 10% of the population, the entire world population, will be highly myopic. So this 10% are really the ones we have to focus on, because high myopia is more related to ocular pathology. And if you want to prevent that number to increase, we have to manage myopia from day one, not waiting a single minute, to control those kids becoming myopic. So not waiting that they are reaching -4 or -5. So as soon as they are confirmed under cycloplasia, that we have to put control in place. So that article not only reestablish that it will be the case, but it proves that we will reach the 50% of the population sooner than we expected. So that means that the progression of myopia around the world is faster than expected. So again, we have to act against this, and we have to really, all of us, give a better job, controlling myopia. This third one is really, really important. 45 citations so far. It may be a little bit complicated, but it relates to the scleral hypoxia. We know that the visual signal hits the retina, and from the retina, there are some biomarkers, biomodulators that will influence the choroid, and the choroid will influence the sclera to become more resistant to elongation or less resistant to elongation by the rearrangement of the collagen fibers. This article proved that one of the mechanisms behind this rearrangement of the fibers is due to scleral hypoxia. So if you have a bad signal at the retinal level, you reduce the blood flow at the choroidal level, and reducing the blood flow will provide hypoxia, and this hypoxia sends another bad signal to the sclera that becomes softer, and then eye tends to elongate more. So it's all about the visual signal again, but it explains the pathophysiology of the eye growth when it's becoming abnormal. So you can certainly read that with great interest. We know that there's a lot of publication and a lot of interest in red light therapy, but this article really is important to consider and to kind of refrain our recommendations about the red light. This article proved that it puts the retina at risk of photochemical and terminal damage. In fact, it may reduce the number of photoreceptors by 20% after short-term exposure. So it's very, very significant. And certainly before recommending that device to a kid and to myopic population, we need more baseline long-term animal study to make sure that the radiation coming from the red light therapy is not harmful to the retina and not harmful to the retina on the long term. We know that there are some anecdotal reports of retinal impact, but that particular article shows that based on the guidelines that we have for laser exposure and light exposure, that those red light therapy devices exceed by far the safety level of radiation. So again, before having a full proof of safety about these devices, and this is why the Chinese government re-ask and ask all the manufacturers to reclassify their device as now class 3 devices, and no one so far was fully recognized as safe. So refrain your recommendation on that. There are other methods that can be useful in order to prevent myopia. Optic neuropathy in high myopia, glaucoma, it's very hard to define what is a glaucomatous optic disc compared to a non-glaucomatous in high myopia because of the distortion of the optic nerve and certainly of the lamina criblosa. We know that the stretching of the eye will impact the lamina criblosa, and the fibers will be less resistant to a normal pressure inside of the eye. So this is why in high myopia, glaucoma may develop with normal pressure. Pressure is still a risk factor for glaucoma, but if the lamina criblosa is damaged by the stretching of the eye, it becomes more difficult to treat and more difficult to diagnose because it's a distorted optic nerve, and it's very hard to tell if it's a glaucoma damage or just stretching or staphyloma from high myopia. So again, this article is very inspiring on that and gives clues about how to make the differential diagnosis. Mechanism of emmetropization, again, as I mentioned, it's coming from the visual signal to the choroid and to the sclera. But this article point out that the retina is able to detect the defocus and the type of defocus, and in order to inhibit the eye growth or to favor the eye growth. And certainly it's an open loop as they define it, and a feedback at every second, every moment. So this is why it's really crucial when you install and recommend a myopia treatment to have full compliance about length of wear. So in glasses, for example, you have to wear anti-myopia defocus glasses all the time, not removing them to play outside, not removing them to read, not removing them to do any kind of work, because this is a constant mechanism that is happening at every second. So we have to keep on the treatment that we apply on the eye to influence the visual signal at every moment that the kid is awake and doing something with his eyes. Influence of age and race on axial elongation in myopia children. This particular very good paper from Mark Bullimore and Noel Brennan established for the first time kind of a reference database for the normal evolution based on the race, age, and gender of myopia and axial length. Again, if you want to evaluate very carefully myopia evolution over time, it's not the diopters that matters, but more the axial length. And these tables provided in this article will show you what is normal, the normal evolution if we do nothing, so you can compare your efficacy. So let's say that this kid at this age with this ethnicity would have increases axial length by 0.4 millimeter. If we do nothing, then installing or recommending a myopia management with glasses, contact lenses, or atropine, then we have a 0.2 millimeter axial length progression. So compared to the 0.4, that is the normal for this kid at this age with this ethnicity, then we have 50% control, and this is what we expect habitually. If we can go over than that and more than that, it's better. But then it's a reference table to see how efficient we are in different populations around the world. Complications of high myopia and update from clinical manifestation underlying mechanism. Again, it's all about the development of high myopia and the related crystalline lens pathology, the atrophy, and the tractional maculopathy. It describes, in fact, what can happen when the myopia becomes very high, and it gives all the reasons to manage myopia properly. To alleviate those pathology to develop over time is very, very important. High myopia, again, a lot of publication on this, 19 citations for this one, for the number 9 most cited paper in 2024, reviews of myopia control strategy and myopia complications. To make a long story short, this article proved that any kind of myopia management, if compliance is there and the lenses are designed properly and the lenses are doing what they are supposed to do, they are all equivalent. So regardless of the method and the strategy you will define, you'll get the same efficacy. Combined therapy with atropine and glasses, for example, may be another option to go over that average efficacy. But that means also that it's the average. The kid in your chair is not the average. So it's very possible that a particular strategy for this particular kid here is not working as expected, and then this is why we have to follow up them very closely. And if it's not working as expected, we have no control, for example, then look for compliance, number one reason for failure, and second one, that strategy may not provide enough dosage of defocus or controlled in order to control the evolution of this kid. So we really have to switch over other strategies at that time. But again, in general, they are all equivalent as long as compliance is there. So glasses are equivalent to contact lenses and atropine, as long as the products you prescribe and you recommend are backed up with solid science. There's tons of products that are launched in the market on an everyday basis, especially from the East Asia, and a lot of them are not backed up with long-term randomized controlled trials, and you cannot trust them, really, because if the manufacturers say, okay, I have a defocus lens and it's working, what are the proof? Where are your studies? Is it a long-term study or a 6-month study or just 1 year or 2? 1 year is better than 6 months, 2 years better than 1 year. There are products there with 6, 7 years of studies. These are really, really good. 1-2 year studies becoming a very solid background. But again, look at the literature, ask manufacturers about their studies and the proof that they are efficient. Otherwise, do not recommend those products because it may not be efficient for the kid. Association between screen time exposure and myopia in kid. Again, it's not the screen per se, it's distance, the surrounding lighting, the fact that we are in a closed environment indoors, and the more time you spend on screen, the less time you spend outdoors in a proper environment. So again, the risk of developing myopia and high myopia is higher if you have more time in front of the screen, but it's multifactorial. It's not the screen themselves. But again, it's good recommendation. Remember, 2 hours outdoor, limit screen time, no screen at all before the age of 2, between the age of 2 and 10, 12, 1 hour leisure time outside school activities. Over 12 hours, it's 1 to 2 hours per day. of leisure time, no more than that, with pauses every 30 minutes. What is required by school is required by school, but otherwise it's 1 or 2 hours of screens maximum per day, including phone, tablets, and computers. And certainly that may help to control myopia on the long term. Now let's go on the 2025, the 5 articles most cited so far. The 2025 is not ended. Just 5 citations so far for the number one, but again, it's very early in the process, published in January. So that one is prevalence and trend in myopia and high myopia in China, systematic review meta-analysis. Projection is astonishing. Already 50% of the population going to 61 in 2050. And the overall myopia will just increase over time as the age is going on. High myopia 5.3. And remember, that high myopia is highly correlated with pathology. So maculopathy, which is a blinding disease, 5% of the entire population of China is affected by that. So for public health system, it's a real burden that is coming. Again, that reinforces the message that we have to prescribe the right products to control the myopia upfront as soon as kids are developing myopia. Second one, extracellular matrix sickness, again, about choroid and several reaction to visual signal. This one here, effect of 0.01 atropine eye drops combined with optical treatment to control low myopia. So they compare with orthokeratology to compare with one type of defocus glasses or single vision, and with no surprise, combination therapy gives better result than single therapy with atropine and defocus glasses. And atropine alone is at 0.01 is no longer a standard of care. We know that it's not efficient enough. Compound medication, there's one coming, at least in the US market and Europe, based on another formulation with heavy water. That may be a different story, but for the moment, we rely on compound medication. 0.01 standalone is not what to recommend to young kids. It's 0.05 minimum. But in combined therapy with, defocus glasses or contact lenses or 2K, it may be the boost that you need to increase your efficacy or to well control that kid that is control, but not that much control. So when you add atropine, it helps, of course. Choroidal thickness in pre-myopic children after repeated low-level therapy and their role in predicting myopia environment. So in fact, they look at the choroidal reaction for the first weeks after red light therapy. And if you have a very good choroidal response, you may predict that on the long term, you will have a good outcome, a favorable outcome. This is true also for glasses, contact lenses. If you can look at the choroidal level and you see an increase in the choroidal thickness that is sustained as long as the visual signal is in place, then you can predict that over 1 year, 2 year, 3 years, you will be efficient with that kind of pathology, strategy. So to the contrary, if you have not a so well good reaction with the choroid remains thin or do not increase in thickness, you may see that this strategy for this kid in that particular environment is not working, and then you can switch over, not waiting for a year or a year and a half to see a bad evolution of his axial length. And the final one in 2005, digital screen time and myopia, again, a systemic review. They established that the daily 1 hour increment in screen time was associated with 21% higher odds of myopia. So that's a lot. So this is why we want to limit to 1 hour before the age of 12 and 2 hours maximum over the age of 12 of leisure time in front of screen, because any hour more than that will increase the odds of myopia by 20%. So that's significant, especially over 4 hours per day of exposure. This is the worst of the worst. And we know kids, in the weekend that can spend 8 hours in front of the screen. So this is really detrimental. And our job as eye care practitioners is to advise parents and make recommendations appropriate to these findings. So let's take a look at the summary of all the other interesting, not most cited but interesting articles. One of the game changer, it was the National Academy of Science publication in December 2024, defining myopia as a disease. And that's a game changer. Why? Because if I have a disease in my exam chair, I have no other option than to treat it. It's not, I will wait for something else. No, now it's standard of care because myopia is a disease. It's a blinding disease. And if we do nothing, high myopia can lead to blindness. So we have to control that. Must read alert again. If you want to establish an algorithm how to implement your strategy, this is a very good article coming from the European Society of Ophthalmology. They develop an algorithm in how to intervene. So I don't do a lot on that because it would take 1 hour just to explain everything. So, but very briefly, you treat the binocular vision first, what is treatable, especially convergence, insufficiency, lack of accommodation. So you treat that with vision therapy, 2, 3, 4 months of that, and after that you implement your strategy. Depending on what you want to do. Glasses are really good. Contact lenses, if the kids are over 8 years old or mature enough, orthokeratology can be considered with all the safety guards, with good hygiene and regular follow-ups. But again, all the strategy are equivalent, so you can select glasses as the first entry point. At least it's probably the most rational and most intelligent thing to do, to begin with defocus glasses and then to switch over contact lenses when the kid is used, and or to combine with contact lenses. I have a lot of kids wearing contact lenses for 8 hours a day, no more than that, because parents are not so comfortable to having them wearing more than that. But it remains 6 to 7 hours during waking hours. I cannot leave them with single vision glasses because I will just do the wrong thing when I try to manage for the first 8 hours of awakening. So I have to prescribe defocus glasses then for the remaining 5, 6, 7 hours, and after that to combine anti-myopia contact lenses and anti-myopia glasses. It's one good thing. That particular interesting paper about the retinal shadows produced by myopia control lens spectacles shows that the defocus of the major brands of the defocus glasses that we are prescribing are hitting the most sensitive part of the retina where it matters. We know that the retina that react to the defocus is around the macular area, 5 to 10 degrees around the fovea. It's not exceeding that. In the far periphery, it doesn't make a difference, but you have to concentrate your defocus and enough defocus in near the fovea in the macular area, and these glasses that were analyzed prove that it's the case. Again, atropine 0.1 in European population proved that in European population it doesn't work. The LAMP study in Asian population proved it doesn't work as well. So 0.1 is no longer what we recommend. Again, topical atropine long-term assessment study, it's a safe approach. But in that case, they look at the cohort who went under the ATOM study, and they look at them over 20 years. 20 years down the road, those treated with ATOM1 with ATOM2 study, and remind that ATOM1, ATOM2 was different concentration of atropine treated for 6 to 1 year in one eye only, and just for 1 year, no longer than that. And then they stopped the treatment and resumed regular single vision glasses. With no surprise, after 20 years, those treated with atropine and those in the control group end up with the same evolution. But you see the treatment during 19 years. So it reminds us that when you start a strategy of myopia management, you have to continue until stability. That means the same axial length 2 years in a row, no more than 0.05 millimeter of axial length evolution over 2 years. And I say to parents nowadays, we start that at 9, 10, 11 years. It will go up until 22, 23, 24 years old, because that's the end. Depending on the studies, you will do college, universities with a lot of computer work implicated. Then we have to sustain and to keep on the strategies and the treatment as long as the myopia evolves. I talked about LAM. This is a 5-year LAM study, and what they prove, in fact, is if you keep the atropine, low dose atropine over the long term, not only it's safe, no side effects, no adverse effect, except light sensitivity and loss of accommodation to diapers in general. But it's a good thing because the kid cannot read anymore. It's a shorter distance. He has to read a longer distance, which is good. We want to have this longer distance, but if you keep atropine low dose 0.05% on the long term, not ceasing it, not stopping it, not changing for 0.25 or 0.01, then this is the best result you can get over 5 years in that particular young population, fast evolving. So again, when you start a treatment, keep on going until stability. That's the message here. Keratoconus is there, and especially in those countries where you are living in with a lot of sun, a lot of sand, a lot of heat, humidity, all that stuff. People are rubbing their eyes, and we see now, and there's a high prevalence of keratoconus in young kids, 12, 13, 14, 15 years old. So you have, before starting, if you have a myopia that evolves fast, with high level, and certainly with astigmatism, and you see that the astigmatism is changing in orientation axis, and it evolves a lot, from -1 to -175, -225, 2 years down the road. It's not normal. Because cornea doesn't move that fast. It may evolve over time, but not that fast. So do a topography. And in my myopia clinic, I do topography to every kid entering in my office because here and there, 30% of them have suspicious cornea, soft cornea, deformable cornea. So we never know which one will develop keratoconus over time. And certainly, I don't prescribe ortho-K on those cornea. There's no proof that I will generate keratoconus with ortho-K, but it's a soft cornea, so I don't want to take any chance at all. So doing topography before contact lens fitting is always a good thing. So let's go very rapidly on the summary of the other articles, the 200 articles that are of interest. The mechanism I explained from the retina to the cornea to the sclera, but what is new is there's also an inflammatory reaction associated with myopia, and it's coming from the intestine, the gut microbiota, that is showing some sort of inflammation, chronic inflammation, and it's linked to evolution of myopia. So very interesting, a few articles on that as well. As for the evolution, we know that genetics plays a role, but it's 30% only. Evolution is more driven by the environment, so this is very important to consider. And high myopia affects a lot of people. Mental health is one aspect we do not measure enough, and our questionnaire now measuring mental health issues, but ask questions about high myopia patients. How do you feel? Because they can be frustrated. They can have difficulty to manage with their high myopia, with the limitations of their vision. And anytime that you may detect something that is going wrong, please refer to the appropriate specialists, psychologists, psychiatrists, in order to help them to manage with their condition. Cycloplegic refraction is standardized care. We have to prove that myopia is there with cycloplegic refraction. And if you have an evolution that is not normal, not expected more than half a diopter per year, for example, redo your cyclo. When myopia is confirmed, cyclopentolate for cyclorefraction, but after that, you can use tropicamide 2 drops. It's as equivalent as cyclopentolate, more comfortable for the patient as well. What about the environment? AI is invading the space of myopia. There's a lot of work on that to help on ortho-K fitting and help also on the diagnosis, glaucoma diagnosis, to evaluate tessellation of the retinal fundus to determine who will evolve, who will not evolve, who will become highly myope, who will not become highly myope. Then there's a lot of that. Nothing really commercially available so far, but it's coming, and keep your eyes on that. As for strategies, we mentioned that every strategy is equivalent. Defocus influence the choroidal vasculature. Atropine 0.05 becomes the norm. I already said that, but make sure then when you cease the treatment, you got stability, you want to cease your atropine treatment, taper your dosage on every patient, even with 0.01, because there's a rebound effect. Small dose response is higher with higher dosage, but there are a rebound effect with every concentration of atropine. So slowly but surely taper that drug when you want to cease it. Glasses, the wearing time compliance is really important. You have to wear them on a regular basis all the time, and make sure that you recommend products that are backed with studies, not the ones that are not backed with studies. Soft lenses, again, those that are backed with studies are really efficient. We have now a few design dedicated to myopia control. Use them first. Those for presbyopia, used for myopia may work, but less compared to what was developed for myopia control, because the mechanism are not exactly the same. And certainly orthokeratology, you have to limit the zone in order to put the defocus inside of the pupil in order to be efficient. As for red light therapy, same efficacy as the other, so you can recommend other things that red light therapy, as I mentioned, there's a lot of concern about the safety on the long term, and waiting for studies on the long term, I would refrain to recommend that kind of strategy at this moment. So in summary, we just got over 250 articles. It's in 30 minutes, so you're good. You're good. You just read what is important in 2024. I can give you the reference if you want. Just email me, and I will give you all the article references. But there's a lot to be discovered. Stay tuned on what is published. Rely on evidence-based. Don't prescribe something that is not backed up with literature. And with this, you'll be certainly successful in your treatment. Thank you very much for your attention.
Thank you, Professor Michaud, for this insightful talk on global insights from the key myopia studies. Now, we'll continue with our next session. I would like to call upon Dr. Yazan Gamo, who will be presenting on the epidemiology of childhood myopia in the Middle East and Africa. Dr. Gamo will share highlights from both personal and regional studies illustrating the rising burden for the childhood myopia in our region. Over to you, Dr. Gamo.
Thank you, Swarna. Good morning, good afternoon, and good evening, everyone. Thank you for allowing me to be part of this very important webinar. Thanks to ZEISS for arranging these topics along with the United Optometrists Forum. Let me share my screen, please. Okay, just give me a sec. Thank you, Professor Michaud, for your lovely presentation. I learned quite a lot of things from that review. So today we're going to talk about epidemiology of myopia among children in the Middle East and Africa. I have no financial interest or relation with any of the products mentioned. I just want to share that I'm the lead author of the following article, Vision Screening and Detection of Ocular Abnormalities in School Children by Teachers in Jordan, which I've cited here and used for my presentation. So Professor Michaud just talked about the global prevalence of myopia, and he already mentioned that more than the expected number of people will be myopic by the year 2050. We remember the seminal Brian Holden paper projection that more than half of the global population is projected to be myopic. This is something we need to remember. Actually, these numbers have already been reached in many parts of the world, including ours as well. We just need to focus at the moment at school-age children, because they are really particularly affected due to increased near work and reduced outdoor activities. And also, as Professor Michaud said, AI and electronics are really influencing our children's education and behavior and interaction with the world. And as he also mentioned, high myopia increases the risk of vision-threatening complications. So we need to worry about how many people will be reaching high myopia in our region, of course. So why focus on the Middle East and Africa? The Middle East and Africa are actually experiencing urbanization and educational expansion, both which are risk factors for myopia. And as you've seen from the global outlook on studies by Professor Michaud, none of the studies mentioned were coming from either Africa or the Middle East. So our regions are really underrepresented in global myopia research. We have data gaps and limited screening infrastructure, which highlight the need for targeted epidemiological studies. So, for those who are not from the Middle East, just a few facts. Roughly 60% of the population in the Middle East is under the age of 25. Today, I had a World Council of Optometry Education Committee, which I chair. And interestingly, we were mentioning about how optometrists can get more involved in the pediatric population. And I was telling them that many parts of the world, including ours, are young in terms of the age of the population. And almost more than half of the population is under the age of 30. So here we go. Urbanization rate is around 58, 60%. So we have good urban background, which means that our children will be more exposed to environmental factors for myopia. And remember, many children in our region sadly face significant challenges related to conflict, displacement, malnutrition, and lack of access to education. These are some things we really need to consider. So, I've cited a review paper, which is funny enough, one of its authors is actually one of our speakers, Dr. Saif Al-Rashid. So probably he should have presented it, not me, but that's all right. So Dr. Saif and Dr. Walid Al-Ghamidi, who is the president of the Saudi Society of Optometry, they've done a lovely systematic review and meta-analysis on the prevalence of myopia among school children in the East Mediterranean region. And their review has shown that myopia prevalence among children is around 15 to 25% of the school children population. And this is quite a huge number. We need to really worry about this. Because if 1/4 of the young population is already myopic, we would expect them to reach half of the population will be myopic probably when they become adults. And as Professor Michaud said, the myopia progression is going beyond the teenage years into the early 20s due to the heavy use of digital devices. And that's one of the notes that I've raised when I was doing my PhD research back in the day, so many years ago, that when I was doing the prevalence of myopia among adults in some parts of the Middle East, that you would expect that myopia will stop progressing by the age 15, 16. No, it didn't. Even up to 21, they were progressing. So this is something we need to consider. So as we're talking age trends in myopia, prevalence increases significantly between the ages 6 and 15. Early onset myopes often progress into higher degrees, so we really need to worry about them. And we have higher prevalence in secondary school students than primary, but we need to detect them very early and manage them as early as possible, of course. So let's talk about vision screening by teachers in Jordan. This is one of the very few methodologically done vision screening studies in the Middle East. It was a cross-sectional. We've done it in the 2023-2024 academic year. We selected 3 schools, one in a low income, one in middle income, and one in high income area. We trained 22 teachers in vision screening methods based on the World Health Organization vision screening implementation, which I was lucky to be part of in developing that document. What we did when the teachers did the screening, actually we compared it with optometrist and ophthalmologist assessment of refractive errors. So we've done full cycloplegic refraction on all those children, which really helped us to understand the prevalence of refractive error in the children. So the screening protocol really, we've done the HOTV logmark charts for both distance and near vision. HOTV are easily the children can simply point, as you can see in the picture, on the letter. They don't really need to know the letter. In the teenage children, they will probably understand it and they can easily spell it. Or if in some parts of my country, English language teaching is delayed, so they might even recognize just the letter. We thought of introducing the E chart for the teenage years as per WHO, but we thought just let's make it consistent and let's use the HOTV. And since this was a logmark chart, at least we are ensuring the spacing, the lines, the contrast is even. So the pass criteria was more than 3 letters from the 0.2 logmar line as per the guidelines. So these are some of the procedures done. So the teacher here will probably show the child the shape of the letter, and one of the teachers here points to the letter. We tried as much as possible to control the environment, so we used the whiteboard to reduce the clutter around the chart. We ensured that the distance between the child and the chart is uniform, that the chart is at the eye level of the child as well. And we should not have used a pointer, but it had made things easier for us as screeners. So what's most important thing for our audience today is the prevalence of refractive error. So the overall sample prevalence was 11%, which is actually less than the review papers done by Dr. Saif. However, remember, we only had children who were 6-year-old and 15-year-old. If we look at the groups individually, the 6-year-old children had around 8% prevalence of myopia, which more than doubled when they in the 15-year group, and it was around 18%. So interestingly, of course, hyperopia reduced quite a lot. But when we always worry about hyperopia, if you think about it, significant hyperopia, and all of these data are cycloplegic refractions, so we really are sure of our data. A significant hyperopia above the 2 diopters, prevalence isn't really that much. It's 11% in the 6-year-old and 4% in the 15-year-old. However, this is a significant number regardless. So, and we need to worry about these numbers. I know we're deviating from our topic about myopia, but as clinicians, we have duties to look holistically at our patients. The good thing about astigmatism, and this is something you really need to worry about, many Middle Eastern children have astigmatism. Almost quarter of them are above 1 diopter. So this is something you really need to consider when you are prescribing ophthalmic lenses for myopia control. The good thing, the humanitarian aspect of this study, when we started the screening, only 9% of the children wore spectacles. When we've done the screening, we've done our vision assessment, we've done the cycloplegic refraction, and we provided spectacles to those who need it. At the end, 22% of the children wore spectacles. That's, for me, is one of the important aspects of school-based vision programs, to let children have access to eye care. Without our intervention, literally 1/2 of the children who were in need of correction didn't receive it. And those children will be labeled as lazy, troublesome, and they will go into too much trouble, and their quality of life would be reduced. Just by going that extra mile, we have literally saved that child's future. Let's move from the Middle East to Africa. And I tend to talk quite a lot, so I need to hurry up. Africa is the second largest continent of the world. More than 1.2 billion people live there. That's almost 16% of the world population. Africa's urbanization rate is much less than the Middle East. However, they are also having the issue of the young population. Almost 40% of African population is under the age of 15. So too many children to manage by us. So this is a review paper that has been done on myopia prevalence in African school children. They followed the PRISMA guidelines. Meta-analysis was done. This is very interesting. Overall, myopia prevalence is around 5%, 4.7% to be exact. It was a little bit higher in females than males. However, that wasn't significant. And we also found in Jordan that there is no significant difference between male and female children. And of course, as we expect, it's a little bit higher in the 12 to 18, let's say 15 year group compared to the 6-year group. However, these numbers are much less than we see in the Middle East. The key findings is the refraction technique. Many studies do not use cycloplegic refraction. For those who use cycloplegic refraction, the prevalence is much less. Those who do not use cycloplegic refraction, they tend to overestimate the prevalence. So for you as practitioners, if you want to read the science, look at the methodology. This is very important. Cycloplegic refraction is recommended for accuracy. So if I've done my study without cyclo, that 8% could have been probably 12 and the 18 could be 25, which is almost similar to the review paper by Dr. Saif, which I know that most of the studies that he reviewed did not use cycloplegic refraction. There is also country variations. We cannot have a one-hat-fit-all approach. Each country has significant variability, probably in methodology, demographics of that country, so I need to think about it. So regardless, from Africa and Middle East, we need to understand limited outdoor activity is a risk factor. That's one of the outcomes that we've reached from the studies that we reviewed. Increased near work, urbanization, and parental myopia are the risk factors identified. Protective factors, more than 2 hours of outdoor time, early screening and visual hygiene education, and hopefully implementing interventions tailored to school-age children. And also the lessons that we learned that myopia affects school performance and psychosocial development. And we've seen high myopia being associated with complications such as retinal detachment and glaucoma. We've also noticed that delayed diagnosis increases the long-term burden on families and health systems. So just the gaps, and I need you to work on it if you are a researcher or interested in doing research. We have lack of standardized nationwide data collection efforts. Most studies are urban-centric. Many studies do not use cyclorefraction, and there is a need for consistent screening protocol and longitudinal data. And my recommendations is to integrate vision screening into school health programs, promote outdoor activity in school curricula, strengthen training for teachers and nurses, expand public awareness campaigns, promote the use of cyclorefraction, and invest in regional epidemiological research. These are the references that I've used, and thank you so much.
Thank you, Dr. Riazan, for your valuable insights. Now, let's move on to our next session. I would like to call up Dr. Saif Hassan Al Rashid from Qasim University College of Applied Medical Sciences, Saudi Arabia, for our next talk. He will be talking on public understanding and parental awareness of myopia. The floor is all up to you, Dr. Saif.
Now you see the screen.
Perfect. Yes.
Okay. I'm so sorry for this.
No worries. Thank you.
Okay. Good evening, everyone. Thank you for the organizing. My special thanks to this company to invite me to produce my lecture my presentations about public understanding and parental awareness of myopic complications and management. Yes, as you know that the current increase in the prevalence of myop is worldwide concern. This could be because of significant amount of the time that the child spent in near activities such as reading and using computer or a smartphone. Yes, a recent study shows that genetic and environmental factors such as spending outdoor activity are the main reason for the high prevalence of myopia. The recent systematic review found high myopic prevalence in the children, particularly in Asia, other than the continent. And the recent study shows that the prevalence of myopia is rapidly growing, and this study predicts that by the year 2050, about 50% of the world populations become myopic. For that, rising awareness for myopic preventions and control is very important. Yes, the questions, why rising awareness of myopia is very important. Yes, this is a very important question for eye care professional. Why raising awareness about the myopia is important? As you know that raising awareness about the impact of uncorrected refractive error particularly particularly myopia is very important as it is a facilitate early detections and effective management of eye conditions. There is a lot of published study about knowledge, attitude, and practice about myopic control and interventions. Yes, and this study found that public awareness of myopic risk factor and management is the low. Yes, the public awareness about myopic risk factor and control is very low among the community as well as among the parent. Yes, the study recommended that eye care professionals such as the optometrists, ophthalmologists should conduct awareness program to educate the community and promote the myopic control effectiveness and practice. Yes, and also this is a very important question for eye care professional who is at risk for myopic development. It is very important for eye care professional to understand or to know or to have a knowledge about who is at risk for development of myopia and to deliver this knowledge to the community and to the parent. Yes, myopic risk factor include genetic and environmental factor. Yes, this is a risk factor for development of myopia, genetic and environmental factor. While genetic factor cannot be changed. Yes, the genetic factor cannot be changed or difficult to change. Change can be done for the environmental factor. We can change the environmental factor to reduce the prevalence of myopia or to reduce the risk factor of development of myopia. For the eye care professional, it is very important to raise the community awareness about the about the environmental factor that could lead to increase the prevalence of myopia. Yes, as you know that environmental factors such as the spending extended period of time on close-up activity, this increased risk for development of myopia by 2.5. Yes, it is very important to raise awareness about the community and the parent about this risk factor for development of myopia, such as the spending extended period of time lead to to high development or to put the child under the risk for development of myopia. Yes, spending extended period of reading or using screen at the close distance, this is increased risk for development of myopia about 6 times. All this environmental factor, we can rely on this environmental factor to reduce the prevalence of myopia. Yes, outdoor activity, yes, not spending enough time outdoor activity. Yes, the study found that if the children not spend enough time on outdoor activities, this lead to increased risk for development of myopia about 1.5. And also the living in highly populated area or living in city, also this lead to increased risk for development of myopia. But we need to raise awareness or to increase awareness about the parent and about the community about this environmental factor. If the parent or community, if the parent or community yes, understand this environmental factor can control their child, and this could reduce the high prevalence of myopia. Yes, the genetic factor, also the genetic factor play a role for development of myopia, and also ethnicity have also role in development or have a risk for development of myopia. Just environmental factor is difficult to change. We can increase the awareness of the parent or community about the environmental risk factor that lead to development of myopia, and also the severity of myopia and risk and severity of myopia and their relation to the risk factor. Yes, for eye care professional or for eye care provider, it is very important to raise the community awareness about severity of myopia. For example, high myopia have a high risk factor for development of conditions such as the cataract, glaucoma, and other eye conditions. Yes, myopia often worsen over the time, raising the risk of serious problem in adulthood. And high myopic level increased risk of retinal detachment, glaucoma, myopic degenerations, and cataract. Yes, we need to raise awareness or to increase the awareness about these serious conditions associated with high myopia. Yes, serious eye conditions are more common with high myopia. Even small degree of myopia have some risk factor to development of some eye complication. For example, if you look here, yes, the mild degree of myopia, yes, increase risk to development of macular degeneration about yes 2.5 times, whereas the high myopia increased risk for development of myopic degenerations about 41%. We need to increase, we need to yes show the parent or community about the risk factor of high degree of myopia, and also the mild degree of myopia yes increased risk for development of retinal detachment about 3.1, whereas the high myopia increased risk for retinal detachment about 22. Yes, and cataract development and also the high myopia increased risk for development of posterior subcapsular cataract. We need to increase the awareness about the parent, about the risk factor. If the parent or community understand the risk factor of myopia, myopia is now yes classified as a disease, not as the refractive conditions before. If the community or if the parent understand this risk for myopia, can control the myopia early or can seek for their child for early vision screening. Yes, why early intervention is very important. Yes, many studies recommended that early intervention is very important, yes, for the children or for the childhood eye conditions. And reduce the early yes, the early interventions reduce the likelihood of development of high myopia. For example, we see in the picture the mild myopia have a less risk factor for development of eye conditions, but high degree of myopia associated with the high risk for development of myopia. Yes, we need to increase the awareness of the parents about early interventions. The early interventions could reduce likelihood of development of high myopia, maybe just a child be in low myopia. Yes, myopic impact the quality of life if not addressed. Yes, myopic yes affect the quality of life if not addressed. Some study found myopia affect the academic performance of the children. We need to also deliver this knowledge to the parent that if your child is not corrected accurately or if not wear their glasses accurately, may this lead to development of high myopia, and high myopia could affect the child academic performance. Yes, what treatment options are available to slow down the worsening of myopia? Also, this is a very important question for eye care professional. It is very important to increase the awareness of the public and community about the options that are available to slow down the development of myopia. There is a lot of options now available for slowing down or for treatment of childhood myopia. First, for example, eyeglasses. Yes, eyeglasses, just there is a special type of eyeglasses. There is a special design for eyeglasses that to slow the worsening of myopia. This just we can tell the parent there is a special eyeglasses designed to slow down the worsening of myopia. These glasses are different from regular eyeglasses that simply correct the clear vision. We can improve, or we should improve, the community or parental awareness about this new design of the glasses or the lens that lead to reduce or slowing the progressive of myopia. We can tell the parent about the advantage of the glasses. Just we can say easy to use, and a child can easy to use the glasses, and we can tell him about the all advantage about this glasses, reduce the child from developing high myopia. And also there is some consideration, some children may have active lifestyle that may be required alternative treatment. Yes, also there is contact lenses. There is also contact lenses. There is options of the contact lenses for controlling of myopia. And also we need to increase the public awareness or parental awareness about this type of the contact lenses, and there is advantage of this type of the contact lenses and the considerations of this type of the contact lenses. We need to increase the public and parent awareness about the consideration. For example, proper hygiene is required to minimize risk for eye infections. Yes, now there is a lot of options available to slow down the progress of myopia. Just we are the eye care provider or eye care professional during the eye examinations, or during the eye examination when prescribing the glasses for the child, we can raise this awareness of the parent about this eye disease or about this condition. Yes, and also we can increase the awareness about the community and parent about the eye drops that now available. There is a lot of study shows that atropine could lead to slow down worsening of myopia, or could lead control of myopia. Yes, atropine eye drop are applied. Just we can tell the parent or community that atropine drop are applied at the bedtime to slow down worsening of myopia. Just we can tell him the advantage. Parent can help to ensure the treatment plan is being followed. Yes, and consideration for this treatment, we can also raise the awareness about, yes, some considerations. Yes, temporary side effect, maybe the atropine. Yes, if the child uses atropine, there is side effect of this atropine. Maybe temporary side effect include light sensitivity and blurred vision. Yes, and also we need to, yes, improve the awareness or try the awareness about use of atropine in control of myopia. The atropine does not correct the child blur vision, so the eyeglasses or contact lens will still to be used. This is a very important point. We need to raise the community and parental awareness about this. Atropine does not correct the child vision. Yes, if the child uses atropine to control there is myopia, this child still need to use their glasses. Yes, and also there is what is the myopic management at home. Yes, the environmental factor that lead to increased development of myopia. The parent can play a role on myopic management at home. Yes, parental have a role. We need also to increase the role. Yes, we need to increase the awareness about the patients, about the parent and community, about the myopic management at home. Yes, lifestyle modifications. Yes, the lifestyle modification can lead Yes, lifestyle modification can help to delay, slow down worsening of myopia. Can lead to delay down worsening of myopia. Yes, yes, increase as mentioned by the professor in the previous lecture. Increase the time spent outdoor. Yes, spending at least 2 hours daily. This lead to reduce the prevalence of myopia. This lead to reduce the prevalence of myopia. Yes, we can recommend some activity to the parent, like visit the park or the beach. This lead to increase time spent. Outdoor activity such as the visiting park or beach. Yes, engage in outdoor sport like football, swimming, or cycling. Go on nature wake and hike. All this activity can lead to increase the spend. Yes, outdoor activity. The spending outdoor activity, at least some study recommend is that spending at least 2 hours daily could lead to control of myopia. And also reduce the time spent on close up activity. Yes, also this can be managed at the home. Yes, we can tell the parent, encourage your child to take a break when doing a class work or homework. Yes, just to take some break during doing work. And it is recommended that they take a break after 30 minutes of reading and increase the distance between them and their work. Yes, because this one of risk factor for development of myopia. If the child focusing on the near, just we can increase the awareness of the parent that their child should take 30 minutes of reading or increase the distance between them and their work. Yes, and also practicing elbow rule by instructing them to place the palm on their head, and the screen or paper should not closer than their elbow. This is also very important, just to increase the distance between the child and the object or the smartphone that used by the child. And yes, also set up limit, time limit on phone and tablet. Yes, there's some app the parent can able to control their child phone or tablet to control the time for the child. Yes, the study found that for the children older than 5, aiming no more than 2 hours of screening time day. Just if the child their age older than 5 years, just to use their phone 2 hours per day. If the children 2 to 5 years old, aiming less than 1 hour per day, we need to deliver this knowledge to the parent. And for the children less than 2 years old, screening time is not recommended. If their age less than 2 years, the screening time is not recommended for these children. Yes, using daily log to track close-up screen and outdoor activity. All this, myopic management at home. Yes, the parent can use log, to track the close-up, and outdoor activity for their child. Yes, monitoring daily close-up activity time and take a frequent break, ensuring that the distance between the child and book or computer or tablet at least elbow distance away, just to increase the distance from the child, or to increase the working distance for the child. Yes, spending at least 2 hours of outdoor activity, as I mentioned in previous study, could lead to control or reduce the prevalence of myopia. Yes, include a simple daily log templates that can be used to track myopia. Yes, this is a logbook template is from Global Myopic Awareness Coalitions. Yes, there is a website of Global Myopic Awareness Coalition. This website have a lot of information about how the eye care professional could lead to increase the public and parental awareness about myopia. This template is a very important template. You can give this template to the parent and just to track their child activity, such as the time spent outdoor activity, yes, morning, afternoon, evening, type of the lens used, symptoms, if there is any symptoms for the child, time spent on close-up activity, morning, yes, if the child used any eye drop like atropine, yes, comment about adherence, yes, there is, if the parent follow this, if the parent follows this adherent or not. Yes, following yes, that outdoor time recommended about 2 hours daily. Yes, outdoor activity about 2 hours daily. Just the parent can yes tick on this or follow up reading distance recommended about 30 centimeter away and follow yes screen time recommended. Yes, take a break for reading and wear prescribed eyeglasses and if they use eye drugs. This is a very important template. The eye care professional can use this template and yes, give this template to the parent to follow the activity in home. This in home management or in home treatment of myopia. And also, many studies indicate that the annual eye examination is very important. Why is the annual eye examination is a very important? Also, during eye care examine or during the vision examination or eye examinations, the eye care professional should increase the awareness of the parent and community about the importance of the annual eye examinations. Yes, the children need regular eye examinations to ensure healthy eye development and to take the vision problem like myopia earlier or other eye conditions earlier. Yes, kids often did not realize they have a vision problem, so the parent may not notice them without eye examination. Yes, sometimes child not aware about the symptoms of the blurred visions or symptoms of diplopia or any eye symptoms. So the parent may notice these symptoms, and sometimes without eye examinations for the parent, it is difficult to detect or to show any signs of the eye problem. Yes, some kids show signs like squinting or sitting close to screening, but not always. This not always. That's why the annual eye examination is very important. We need to deliver this knowledge to the parent or community about the importance of eye examination. Yes, needed education interventions. Yes, limit awareness. Many studies show is that there is a limit awareness about myopia. Myopia control risk factor and management. Yes, lack of knowledge on preventions and control strategy. Also, many of the the study shows that many of the parents not understand the methods of preventions of myopic or control strategy for myopia. Yes, important for target educated for public and the parent. Yes, it is a very important we as we eye care profession or eye care provider to target and educate the public and parent about yes about the interventions and about the prevention methods and about the the control methods and about the methods of the treatment that available for myopia. Yes, public health campaign. Yes, this is also very important to yes increase the public awareness about myopia. Yes, utilize social and public yes and public media. Yes, we can use social and public media. You can use social media like X or Facebook and other media. We can use this. Yes, we can use this social media to increase or public media like radio or TV. We can use this to increase the public awareness about myopic control and treatment and yes, the treatment available for myopic control. Yes, focus on risk factor or of uncorrected myopia. Yes, during the campaign, it is very important to focus on the risk factor of uncorrected myopia. If the parent or community realize about the risk factor for high myopic, just they go to seek the treatment for their child. We need to improve the awareness of the parent and community about the risk of high myopia, promote preventive measures and regular eye examinations and checkup. Also, this is very important. Yes, school and community out research. Yes, this is also very important. Implementing a school-based program. Yes, school-based programs such as for vision screening, for campaign to raise awareness of the child, teacher, parent about myopia and about the method for controlling myopia. Engage the community, especially in the remote area. And also we need to yes improve the awareness of myopia in also in remote area. In remote area now, the myopia is high also in some rural area. In some rural area, there is some study show it high prevalence of myopia, and also it is very important to raise awareness in remote area and bridge the knowledge gap through interaction session. It's very important to raise the awareness through the interactive section. Yes, interactive sections is very effective during the eye examinations. During the eye examinations, when you examine the child and you write the prescriptions, you can deliver the knowledge about the myopia and knowledge about the options for treatment that are available for myopia control during this session. This is very important. Many people take any advice from the eye care provider or from the doctor in very serious way. Yes, this is a very important to give the knowledge to the parent to during the eye examination. Yes, role of eye care professional. Yes, ophthalmologist, yes, optometrist, ophthalmologist to provide yes a counseling, yes a consistent message on myopia control. Also, we need constantly send message to the community, to the parent about the method available for myopia control and about the risk factor for developing high degree of myopia. Yes, educate on potential complications. Yes, initiative like Myopic Week, yes, yes, like Myopia Awareness Week. Just we can put or some week or there is I think there is in WCO there is a week for myopic control. We can use this or we should use this week to raise the myopic awareness. Yes, yes, encourage public participations and engagement. Yes, collaborate with the health organizations. Yes, in the local area or in the international level to increase the awareness of myopia. Yes, in conclusions, myopic awareness is very important for public health. Yes, education and intervention can make a significant impact on myopic control and treatment. Eye care professionals should organize public awareness program to enhance community knowledge and practice on myopic control. This my references. Thank you.
Thank you, Dr. Saif. And we hope that in this region, optometrists will be playing a leading role in the management of progressive myopia. Dr. Peter Essig is our next speaker. He is medical science liaison for ZEISS Vision in the Gulf, and he earned his doctorate from the ZEISS Vision Science Lab at the University of Tübingen in Germany. And he'll be informing us of the latest technical updates on ZEISS's lenses for childhood myopia. Thank you, Dr. Peter.
I hope my screen is visible and you can hear me. Is it so?
Yes, loud and clear. Please carry on.
All right. Perfect. Thank you very much. So thank you again for welcoming me for this amazing session. Also, my biggest thanks to my previous speakers, Dr. Saif, Dr. Misho, and Dr. Niazangamuth. All really nice presentations. So really also thank you from my side. It was really inspiring and great to see your work. I brought today a short keynote about ZEISS MyoCare, science-driven innovation for myopia control by ZEISS. So the agenda for today's session will cover first some introduction and challenge of myopia. We learned some of those points in the previous talks, but just to get some recap here. Then we will move on to the background of ZEISS myopia management, what we've been through the last quarter of a century, then some considerations of the ZEISS MyoCare lenses and beyond. Then we will move on to the assessment of the clinical performance as we learned today, this is really a cornerstone and a super important point to mention. And we will finish the presentation by showing some numbers on adaptation and variability. So I'd like to start my introduction with this picture, which is pretty similar what we have seen in the previous keynote, which is actually showing what myopia can actually lead to, what the day-to-day implications for the young kids can be, especially in China. So this picture is obviously taken in China, where the situation is the worst on our planet. So on one hand, we can say, okay, we can learn from them because of such a big problems. On the other hand, we can really see what one can say a trivial eye disease or trivial eye problem can actually lead to. That the students, the young kids, have to study under such conditions, being placed behind the bar to maintain a proper gaze position, which is rather sad, right? And definitely we want to avoid such conditions for our children here or elsewhere. So that's why myopia management comes to the game. And if we stay in China, here I brought for you longitudinal data over 20 years of time span covering from 1995 to 2014. So we have 20 years of myopia involvement throughout one country, split into 34 provinces, I think China has, which actually shows a couple of things, right? So first, in 1995, we can see that the right side of the country, where the biggest cities as the capital Beijing or Shanghai and so on are placed, were always highly associated with myopia, right? Rather than the rural areas, they were doing pretty fine. The other thing what we can see here is that over the 20 years, the situation changed dramatically. So the areas that used to be fine, they turned to be yellowish, light gray, and those areas that used to be yellowish turned to be gray. So again, as was mentioned before, not everything can be just argumented by genetics, because probably we wouldn't see such effect to be that fast, but rather than the behavioral changes, and these are the outcomes in terms of myopia prevalence. Also found locally by Dr. Niazan Gamuth, who had a nice speech today. He actually found a similar thing. So here, coming with the data from 6 years old and 15 years old children under cycloplegia refraction, those kids actually doubled in terms of myopia prevalence over just 9 years. So again, we can see a similar trend compared to Asian-like countries here. And this was also, so to say, to some extent said before, that myopia, it's not about a minus lens, it's not just about a basic eye disease, but here we are rather unfortunate because we are highly associated with some secondary eye problems like maculopathies, open-angle glaucoma, subcapsular cataracts, retinal detachment, and so on. And suddenly we shifted ourselves from, like, as I'm saying, a basic refractive error to an eye disease, which is rather irreversible and has a tremendous effect or impact on the day-to-day life, right? Limiting yourself from day-to-day activities and so on. So again, another argument why to apply myopia management, because again, we want to avoid such sort of statuses. And whenever there is such a big story in terms of vision care and medical care, ZEISS as a foundation was always in a really close touch with the top niche scientists. And I always like to share this story, which is more than 100 years old as of nowadays. Is basically telling how the first slit lamp, how the first precision spectacle lens or the first intraocular lens basically come to us, which nowadays is a normal product for all of us, right? But 100 years ago, it was not the case, right? And ZEISS back then came into collaboration back then with Avar Gulstrand, who was a laureate of the Nobel Prize for his descriptive eye model, for example. And basically, they together developed such things. So we learned from our past, and as you will see today, we basically copy paste and apply the same paradigm for myopia management. So the background of ZEISS myopia management, which is a chapter number 2 of my keynote today, is actually showing first of all this 25 years of timeline, what we've been through. So starting with early millennium, with some basic understanding of myopia, progression, what is myopia, why the eye so elongates, and so on. Then later on, we established our first research and development center for myopia eyeglasses and lenses. We also established the first collaboration with first clinical and scientific institutions. Later on, the first myopia management lenses, back then called MyoVision and MyoKids, came to the market. Also, the ZEISS Vision Science Lab was established, which is a one-of-a-kind industry on campus where Carl Zeiss Vision as a company and the University of Tübingen in Germany come together. Again, that ZEISS has as close touch as possible to the scientific field. And later on, everything was expanded to the global scale. And our latest advancement then is the ZEISS MyoCare lens, as well as the Myopia Advisory Board. Here also to mention is that ZEISS is solely a foundation-owned company. So here the pure focus is really on the value, science, public health, and the customers and the patient. And before we move to the lens itself, I would like to introduce you the ZEISS Myopia Advisory Board, which is one of our latest advancement, as we have said. And again, really comes close to the 100-year-old story I shared with you before. And this is the collaboration with the top niche scientists. Yeah, so ZEISS really is so lucky to have all those highly esteemed people on board, helping the company to be scientifically correct, to run proper clinical trials, and at the end of the day, to have top niche solution that really works under all conditions. So the considerations of the ZEISS MyoCare lenses and beyond, starting with this slide. So for those who didn't see the lens yet, it's a spectacle lens. So really a lens that comes to a kid's frames. And the lens has a specific design for myopia management. So we aimed here to really have such an optical design that would force the eye to grow in an emmetropic-like way. Yeah? So we do not want the eye to stop to grow, but also we do not want the eye to grow too fast over time. That's why such a design. Just to mention, those circles on the lens are just on purpose of a presentation. They are definitely not as vivid as it's depicted here. However, on the front surface, we have those care elements. Care actually stands for cylindrical annual refractive elements that hold a certain defocus power and actually are aiming to shift the peripheral image in front of the retina, which was found out to be one of the triggers why the eye actually wants to elongate, and also why a normal single vision lens might not be the optimal solution, because it will simply not modify, due to the optical modalities, the peripheral image. So that's why here the ZEISS MyoCare is designed in such a way that we basically shift the peripheral image with the defocus elements in front of the retina. On the other hand, to maintain a nice variability of the lens, we have clear zones in between that basically hold the same refractive power as the center of the lens, where the kit is normally corrected for distance. And at the same time, then we treated the back surface in such a way that regardless you would make a ray tracing through the defocus element or the clear zone in between, you will always find a focus in front of the retina. Yeah? So we also took this into consideration, that by whatever means, there is no hyperopic defocus, as you will also see in the future slides. All right. The 3 pillars of considerations for the care lens was, first of all, the size of the center clear zone, which we found out that it simply can't be just a random one, but it has a certain level of limitations. Secondly, the design of the cylindrical annual refractive elements and the lens back surface. And the third pillar is the fill factor, meaning the relative coverage of the peripheral zone of the lens, covering the defocus elements and covered by the clear zones in between. But taking it step by step, first we will come to the size of the central clear zone. So there were two arguments, and unfortunately for us, coming to some extent against each other, because on one hand, we needed to be big enough to enable all the daily activities, because this is also what we learned with our previous designs, that if the children will simply not like the lens, they will not wear it. And if they will not wear it, your myopia management will simply fail. And here, as it was also said before, we are targeting really extended wearing time. Yeah, so at least 10 to 12 hours a day. On the other hand, however, we wanted the aperture or the central clear zone to be small enough to establish the first defocus element or the functional zone already in the mid-peripheral retinal region. And why is that? Because it was found out by Dr. Frank Scheffel that already the mid-peripheral retina, meaning here 6 to 10 degrees, is a sweet spot for positive defocus detection and alone can regulate the eye growth control mechanism. Yeah? So I believe that it was to some extent stressed out by Professor Michaud, this one. And here, this article I would take as a must-read number 2, yeah, because it's a really nice work where they really played around with defocus in different retinal locations, and they found out that the mid-peripheral retina is actually the sweet spot. As a footnote, it's most probably because of the relative distribution of the SML cones, while on this retinal region, the S cones are percentage-wise the most prevalent. All right, then we can move onwards and come to the cylindrical annual refractive elements and the lens back surface. So first of all, I would like to draw your attention to the top right corner where you see basically the heat map, which is basically showing how small the elements are. Yeah, so we are really talking about small and tiny elements which are about 0.5 millimeter wide and about 400 microns height, which in ratio to the defocus those elements yields, they are the smallest on the market currently. Yeah, so it really took a tremendous amount of time to really be able to manufacture this, but yeah, yet achieved. Then if you move your attention down there, it's basically showing you the spherical error across a range of the lens, showing again how the back surface of the lens actually performs. So regardless whether we make a ray tracing through the clear zone or through the defocus element, we will always find out that there will be induced myopic defocus, meaning all the images of the peripheral retina will be shifted in front of the retina and no hyperopic defocus is actually present. In terms of the design of the optical output, let's say, of one single element, as you already learned, the CARE is an abbreviation standing for cylindrical annual refractive element. Yeah, so we are talking about a cylindrical-like optical defocus, optical design, which basically we found out to be the easiest one to adapt to. Yeah, so this will be then shown later on how the variability and adaptation actually performs compared to a single vision for the new wearers, and you will see that there is actually no clinical or statistical significance. And the last part, this was the easiest one, is the fill factor. It goes again in the direction of variability of the lens, and here it's 50-50. So 50% of the peripheral part of the lens will be covered with the defocus elements and 50% with the clear zones in between, holding the same refractive power as the center of the lens. All right, in terms of our portfolio, what is actually available? There are two options. One is called MyoCare, one is called MyoCare S. The fundamental understanding, the ring structure, and if you take a look on the lens, you will basically not find out any difference. Yet the only difference here is the size of the central clear zone, which for MyoCare is 7 millimeters. For MyoCare S, it's 9 millimeters. and the mean additional surface power of the defocus element, which is either 4.6 for MyoCare or 3.8 for MyoCare S. So one can understand the S as a soft version, maybe. Yeah. Why we did it is to give all the eye care professionals options based on your expectations, how severely the myopia should progress, whether or not the kit adapts. You can always choose your option and choose between Care and Care S. Coming to the adaptation here, this actually comes with warranties. Yeah, so since we are talking here about a treatment for children, we come with a range of warranties. So if there is any power change up to 9 months from the invoicing date, the care lens can be replaced just for free. If there is any non-adaptation, for example, you start with MyoCare, the kit will complain about some glare and halos, which we can see maybe 1, 2, 3 times out of 100. Then up to 1 month from the invoicing date, you can switch to MyoCare S or a single vision lens, also just for free. What we also support here is a stock lens option. So we as ZEISS also understand that different parents come from different financial levels, so to say. And if somebody would think that this is too expensive, maybe, we also wanted to support here financially. So the stock lens option, which comes in polycarbonate and it's available from plano till -6 in sphere, combined with cylinder up to +2, it's actually available from 950 dirhams per pair, including all the warranties. Yeah, everything above this range, so has to be manufactured. Then we can go up to -10, combined with cylinder up to +6. This needs to be then manufactured in Germany, and it's available in all the indexes from 1.5 till 1.67. The slide was called MyoCare Lens and Beyond. So this is the beyond. What else do we have here as ZEISS in terms of education in your clinical practice? Also explanation, what is myopia about? What are the risk factors, implications, and so on? We designed what we call a Myopia Kids Corner, which is really a designated indoor installment, indoor application. It's about 220 centimeters tall and 1 meter wide. It actually really has a wall covering all myopia information, and it's really meant for the eye care professionals to explain it to the parents and also for the kids to have some entertainment meanwhile. On the other hand, what we also have is a full MyoCare certification and myopia education program. So whoever would be interested to dig even further in terms of myopia understanding, what is available, risk factors, and so on, everything is available online on our website, and it's just for free. You can take your part whenever you want. So basically just type in Google Myopia Education Program by ZEISS, and I believe the first link will guide you to the certified program. In terms of any questions regarding the Lens Kids Corners education program, here is my email and phone number, so you can also approach me whenever you would need to do so. All right, now coming to the fun part, assessment of the clinical performance of the ZEISS MyoCare lenses. And there are several things to mention. So first of all, the number of data points we are dealing with. Yeah, so we are really covering a big data points, big amount of children. So we are really not playing with small cohorts, which might be statistically misleading and due to the standard deviations also like not so scientifically supportive. So we really aim to work with big data points in terms of amount of children. We have two main focus as of nowadays. One is in China, where we cooperate with 3 big universities in Wenzhou, Tianjin, and Zhongshan. The other point is then in Europe, where we have multi-central trials being run in Portugal and Spain, where Madrid and Lisbon are the main hubs. But as of the multi-central trials, also other clinical institutions are actually involved. All right, so first, getting some data here. This is data from Europe. So this is the multi-center trial from Spain and Portugal. covering 1 year. The study is still ongoing, so hopefully next time we will have a presentation and a webinar. Already a 2-year extension will be present, but as of nowadays, at least this. We have basically double-blinded prospective study here, comparing single vision and Myocare. First of all, being focused on spherical equivalent, which is just a supportive measure for us, coming with a 57% of reduction and obviously statistically significant, which is not as important as the axial length, because of course what we target in terms of myopia management is the optimal axial elongation. Yeah, so of course then naturally axial length is then for us the cornerstone, the corner parameter we are investigating. Again, coming from the two groups, single vision and care, we have some data points over 1 year. One can, again, pretty boringly calculate some level of efficacy, which here comes to 62%, which is, however, not telling you the whole story, right? Because if by chance your single vision group will shoot up a bit higher, you will artificially enhance your percentage of efficacy, but you will have no idea whether or not the optical instrument you are presenting to the kid's eye actually forces the eye for the emmetropic growth. So that's why we need to focus on the absolute value here over the 1 year period in the treatment group, which guides us then to 0.08 millimeters as an average annual ocular elongation, and even be so critical, to my opinion, and take the upper bound of the standard deviation, which will then come to 0.11 millimeters as written in the table next to the graphics. Now, what you do with these numbers is that you basically compare it with an optimum or with a limit. And for this, you can use an independent literature, for example, here by Tindemann and IOBS, which is, of course, a trustworthy author, who was investigating what would be the optimal or the non-myopic limit, let's call it, in terms of annual ocular axial elongation progression. We know that our data points came from Europe, and we know that our kids were about 10 years old, which are the two parameters which are basically then like defining your limit. And for those particular kids, it should be 0.1 millimeters a year. Yeah, so this is really now the gold, that what we have seen so far is that from this data we have on those European kids, the care lens really forces the eye of those particular kids to really grow in emmetropic-like way. We can also repeat ourselves from a bigger data points and also much longer or older data from China. So this second graphics I'm showing here is actually from China. We have 24 months, meaning 2 years. Firstly, the eyes with Myocare grew about 0.2 millimeters. Subsequently, over the second year, the step was rather linear, which was also pretty cool to see. The next step was again 0.2 millimeters in the second year. And as again, we can repeat ourselves. We know that those kids were from Asia. We know that those kids were about 9 years old. So we can jump to an independent literature here, for example, in +1, coming just from China. And those kids should grow optimally or be considered as non-myopic by growing less than 0.18 millimeters a year. Yeah, so again, the care lens really shows that it really forces the eyes to come as close as possible to the emmetropic growth, even in such a hard condition as, of course, China is, because of the genetics, behavioral factors, and so on and so on. Yeah, so that was really nice to see. If we combine basically what I've been telling here so far on one slide, this would be basically the outcome. So you have basically two sets of bar plots, one coming from the Asian study, one from the Caucasian study. The first bar shows the annual progression in axial length over the year for single vision, then for Myocare, and then what the emmetropic target was, nicely showing how the care lens really forces the eye to come as close as possible to the emmetropic-like growth. And to also support it like scientifically, we also were present at the ARVO annual conference at the Salt Lake City, where we had one poster actually showing that being more interested in the absolute rather than the proportional effect is actually a way to go and is a way how to read properly the data in all the scientific literature. Yeah, so there are, of course, many ways how the current science is presenting the efficacy of the respective optical solutions. But here we are really showing that the proportional effect might be to some extent misleading and might overestimate the actual effect. Yeah, so always taking a look on the absolute effect and combine it optimally with some independent literature limit is actually the way to go. Another point, how we saw our data, how the CARE lens and CARE S really performed in the clinical practice, was actually asking ourselves what would be the probability if treated by single vision or the CARE lens to achieve fast progression of myopia, meaning here more than 0.75 D per year, showing that when treated with the respective myopia designed lens, the probability of such status is about 3 times lower. And we are coming slowly to the end of my presentation, and I would like to close it here with the adaptation and variability of the ZEISS myopia lenses. So here we are showing what is the adaptation, either ease or time to adaptation in 3 different groups. So single vision, ZEISS myocare, ZEISS myocare S for the first wearers. Yeah, so those kids never ever wore glasses before, and we were really trying to understand whether or not they will perceive any difference, whether they will complain or they will simply not adapt. Yeah, because the adaptation and variability, as I said before, came to the equal level of importance as the performance of the lens itself. Yeah, because again, if they will not adapt too fast, or they will not like it, your myopia management will simply fail. So that's why this sort of comparison resulting in not any particular trend or not any particular clinical or statistical relevance / significance. Also, the variability, when asked the kids on a subjective questionnaire manner, what the adaptation, distance vision, near vision, perception, doing sports, being active, walking down the stairs, and so on, they all perceived very good vision, and the percentage are as shown. I would like to thank you very much for your attention. I would like to thank again to the organization and all the previous speakers, and thank you for your attention, and I'm heading my work. Thank you a lot.
Thank you. Thank you, Dr. Peter, for sharing the latest clinical insights and the technology updates on ZEISS myopia lenses. I am Kani, clinical optometrist with special interest in myopia management, working for Sheikh Khalifa Medical City, Abu Dhabi. It is my honor and pleasure to welcome Dr. Nisar Hashmi, consultant pediatric and oculoplastic ophthalmologist, who will be leading today's panel discussion. I would also like to invite all our expert speakers to kindly join the panel. And I'm delighted to have Ms. Irene Joseph, specialty contact lenses and myopia management consultant from Genesis Healthcare Center, Dubai, to join the panel. And also, please note, at the end of the panel discussion, we will have a quiz. This will have 25 questions to be answered in 30 minutes, which is really going to be a challenging quiz. You can either scan the QR code or click on the link that will be shared in the chat box. So with that, I now hand it over to Dr. Nisar to lead the discussion. Over to you, Dr. Nisar.
Thank you very much, Dr. Suresh. I would like first to thank ZEISS team for gathering us tonight and today for some people, and of course to thank our valuable and distinguished speakers for the really deep insight. I learned a lot of things today, I have to be honest with you, and I will probably implement it in my daily clinic. So I have a couple of questions, and it can be, it's sometimes very genuine questions, and sometimes questions that are asked to me by my patient or parents that I want to ask. And the first question is for Dr. Peter. It was the last one. So we know that when patients are on atropine, we know that there is sometimes a rebound. And one of the parents asked me for children that we start on MyoCare lens. Is there any risk if the patient shift again after a few months of wearing these lenses to a normal like monofocal lens? Is there any risk of rebound? I wasn't able to answer to the question. So
Uh,
what is your answer on this?
So definitely the lens is not harmful. Yeah. So this would be my first ever response. So whether or not you are wearing even in a high healthy eye conditions, you will basically not harm the eye. In terms of the rebound effect, I believe I don't have any data on this now, but to my understanding, it would be much lower compared to atropine, especially the high dose atropine.
So we can say to the family, the parents, that if he starts on
Usually what you do is that if you continue with the care lens and once you find out that the eye really started to grow in an emmetropic-like way, let's say over a 1 year period, then you can be pretty sure it will continue to do so. Then you can switch again to a single vision lens, and then your myopia management is simply over.
Okay. So I will jump to Professor Michaud. I really learned a lot of things on the all the review of the literature you've done. So I used to say to my patient, the rules that I'm giving them is 2-2-2. No screen before 2 years of age, not more than 2 hours of screen per day, and 2 hours outdoor. So I believe that I found all this information in the different words that you gave us. I have a simple question for you said topography most for all of your patient. You said cycloplegia for all of your patient. I mean, are you using axial length? Which method in kids you are using, and how often you are repeating it? That's the first question. And the second question, I think that it was also I noticed it somewhere. What is your usual follow up? How often you see the kids? What is the protocol of follow up that we can like follow in our clinics?
Good question. In fact, the for the topography, it's to detect abnormal cornea and to explain variation of refraction and astigmatism if it's not as expected. And we find in 30% of the young kids some sort of irregularity on the cornea that has to be followed. That doesn't mean that they will have keratoconus in the future, but at least it needs a follow-up. For axial length, habitually it's an optical biometer, so you can have IOL Master. I'm using a lot of Maya from Topcon. I don't want to advertise on everything. Every machine is okay, but Maya is very versatile. You have topography, you have axial length, you have pupil measurement, you have a lot of information from that machine. Not that expensive and very very reliable. The one that I refrain to use in kids is the immersion cell biometer, so where you touch cornea because you never know how to indent the cornea and you have not the same reference point every time, so it may be misleading. So optical devices are best for this. Habitually, I measure my axial length twice a year, every 6 months. As for the follow-up of the kids, as long as they need to be followed, and we know that when we start myopia treatment in glasses, contact lenses, atropine, all that stuff, it should be sustained as long as myopia evolves. It's not a matter of 1 year, 2 year, 3 years. It's a matter of life, meaning that a kid starting at 8 years old, it will not stop before 22, 23, 24. And we have to go on a continual basis with devices worn. Just 1 year or 2 years is not enough to control myopia. Otherwise, it's just like Atom study. They proved that 20 years on the road, the control and the treatment group were exactly the same. Why? Because the treatment was stopped after 1 year. So I'm following my patients habitually every 6 months. Uh, with Ortho-K, habitually it's more than that at the beginning, especially after the first 24 hours recommended. Personally, I don't do that anymore because it didn't show up anything. I didn't change any fit, anything else. So I fit my lens, and the fit is habitually appropriate, and I see the patient 1 week after. the kid has and parents have my phone number. If anything goes wrong in the first week, they can call me at any time. I see them immediately, but habitually I see them after a week, and then after a month, after 3 months, and every 6 months. In soft lenses, habitually I will see them after 1 month and every 6 months. In glasses, it's every 6 months for refraction and actual lens measurement. I also reevaluate after a month in contact lenses. I reevaluate my binocular vision function because it may change from glasses. Of course, we have an exo shift, and sometimes, especially in ortho K, we can have a different scenario. Some patients who were not or very close to be abnormal in glasses become very normal under contact lenses and or with ortho K. So I have to reevaluate these things, and it's like that every 6 months up to the stabilization. Stabilization is defined by the Dutch researcher, the Rotterdam the Rotterdam Institute in the Netherlands, as the same axial length, no more variation than 0.05 millimeter over 2 years. If you get that, then you are stable, and then you can move to single vision correction. And if for ever any reason myopia still continue to evolve, then you go back to your strategy and for myopia control. But up to the age of 20, 21, 22, 23, if they are going to college and university, they are doing a lot of computer, habitually it's valuable to follow them every 6 months.
Regarding the myopia, you said that you taper the atropine.
Yes.
When do you decide? Is it when you reach this stabilization or plateau of progression of the axial length? Is it the moment that you say, let's start? And how long time you taper, and how you usually, what's the protocol of tapering your atropine?
Good question. Again, I'm relying on the Dutch experience because these are the ones who developed the guidelines for atropine as a standalone therapy, though. But it's applicable if you use atropine as an adjunct therapy as well. But habitually, it's until stabilization or the age of 16. They stop at the age of 16 in the Netherlands. And then there's no consensus on how to taper. But habitually, we reduce the dose, half the dose every 2 weeks, even a month if you want to be very, very safe. But let's say that I have 0.05. I would say probably for the next month, you will go at 0.025, and then next month at 0.01, and then after that, every twice a week at 0.01, and then nothing, something like that. So just to land down. Obviously, if you have 0.01 tapering, the rebound effect is less present compared to if you are at 0.05 and 0.5, or because they use that in the Deutsch country, the tapering will take longer, 6 months, because the higher the dose, the longer the tapering should be. The lower the dose, shorter period of tapering. But again, there is no consensus. But it's just to reduce every 3 weeks or 4 weeks, half the dosage that you had before up to the end.
Yeah. We have sometimes patient that starts myopia very late, around 18, sometimes 20. We know that the axial length of the eye can grow up to this age. Do you have in your patient group people who you started on Myocare lens or any kind of defocus lenses at 18, so like at adult age? Do you have group of patients that are considered as adult and wearing these such glasses?
I have a lot of patients, young adults still evolving. So either they were under myopia control before, but some of them are referred for myopia management, and they were never controlled before. Still, 30 to 40% of the young adults will continue to evolve, and they merit some sort of management. The first thing to consider is that the myopia does not evolve habitually that fast compared to younger patients, but it's still evolving in some cases. So to prescribe just like care lenses or other defocus lenses, or even in anti-myopia contact lenses, it takes habitually neuroadaptation. And it's longer for older patients compared to younger ones. So habitually I advise my patients, okay, for the first 3, 4, 5 days, you you may get, some sort of bizarre, you know, view or visual acuity compared to what you had with your single vision glasses, but it will just fade away, and you'll get used to that kind of new visual signal that your eye is receiving. This is because we want to create this defocus that we generate, that we want to control myopia. So it takes a longer time to neuroadapt, but it's worth the effort. And if they can go over that 3, 4, 5 days of adaptation, then we're good to go. Some patients cannot really adapt to this, and then we have to find other ways. Ortho-K is probably the most convenient method then to if they are a good candidate, if the cornea is okay for that, and if the correction is not that high. So it may be one thing. We have off-label some center distance multifocal contact lenses we can consider for young adults, but still, the care glasses and the other ones are very valuable options for them. But make sure that they are aware that it may take a few days to adapt to the design. It will take 2 hours, but some it will take 7 days.
Thank you very much, Professor Michaud. I have one question to Professor Yazan. I loved your epidemiological study in Jordan. It reminded me like a couple of work 20 years back in France, where the National Institute of Research has published like to aware the people, to tell them that one child over seven has a bad vision or poor vision. So in your group of people there, you showed the number of myopic people, the number of patients with astigmatism. Do you
Yes.
recall how many of those patients were anisometropic, having more astigmatism on one side, for instance? Because we know this is the embryogenic factor, the more embryogenic. And I didn't, I didn't see the number of patients and the population, whether it was the whole Jordan or some part of the city. Can you tell us a little bit more about the findings, please?
Thank you for your question. We've surveyed three schools. A total of 500 children were included. They were from the north, the middle, and the south. So it was a representative sample of the school children population. We only chose two groups: the 6-year-old when they enter the school, and the 15-year-old where they will enter the high school. The beginning of myopia, let's say, in children, and at the time where we expect myopia to be reduced. In terms of anisometropia, I didn't show the data, but I recall when we were doing the analysis, I think it was less than 2% of the school children population were anisometropic. I was surprised to see these numbers. I thought they would be more, but that was approximately the prevalence of anisometropia in school children in Jordan, which I believe would be also applicable to other neighboring Middle Eastern countries. If we compare the prevalence of myopia in adults in these countries, they're almost the same. So I would project and expect that the data we found in our sample to be applicable in other neighboring countries that have the same environment, the same educational system. The consanguinity is an issue with us. Sorry, today I was a little bit sick. Celine knows about that. So I apologize.
No problem.
Thank you.
Yeah, take the time for a small cup of water. The question is, we had this issue, I told you, 20 years back in France, and the decision was to make a mandatory screening. We have two mandatory screening for kids at 3 years old, and this is done by like a specific children and mothers care medical system, and another one at 6 years old in schools by medical or I mean, professionals for school. Like there are two different services in order to try to cover all the people there. So that was the decision after these findings. Do you have in Jordan similar, or do you know any in the Middle East? We've tried to work. I'm working in Dubai. We try to implement such screening. And you were talking in the screening of cycloplegia. When we speak about numbers and volume of patient, it's difficult to have cycloplegia. The strategy we've chosen, for example, in France, is to screen kids, but not necessarily eye professionals. It can be sometimes nurses or teachers. Sometimes we have optometrists, orthoptists, and even physicians. We choose to screen the kids with two lenses like that are ready with +1 or +3. So we know that if a child is like more hyper op than +1 or +2, it's enough to say to non-eye professional that something is going wrong, and then we send him for a better and deep exam. And if the patient, of course, is myope with a +1 in front of his both eyes, the vision will be dropped.
Of course.
What is the strategy you think of planning or applying in Jordan, and according to your experience?
Thank you for that question. We did the cycloplegic refraction by ophthalmologists and licensed optometrists to ensure that the children that were positively detected by the screeners that they had a refractive error really had a refractive error, and for us actually to have an epidemiological data on the prevalence of refractive error. The screening was done actually by school teachers. We did a 2-day training for them where we taught them what is visual acuity, what are refractive errors. We brought them vision screening kits, charts for distance and charts for near. We taught them how to use the occluder, how to point at the chart, and to which line they need to point at. And if the child reads more than 3 letters, then the child would have passed the test. We did use a +2 and -2 flipper lenses to see if the vision gets worse or the vision gets better, to help us, to see if there's hyperopia or myopia. The data still is under analysis for the +2 -2 approach, but we thought at least in alignment with WHO guidelines for vision screening, we just use the chart. If they see less than 6-9 letter line, then they would be referred. The referral system here, we are currently implementing a national system that is supported by a non-government organization where the teachers will log the data into the school system, which is linked to the Ministry of Health. They are referred to health centers that are managed by the King Hussein Foundation. It's a non-government entity. They will receive a free of charge full vision examination by either a licensed optometrist or an ophthalmologist with full cycloplegic refraction if indicated. And they will be offered free spectacles as part of this initiative in the country. We've done, I think, more than 200,000 children in the last couple of years. The data is still ongoing and the work is still ongoing. By December, we'll have a summary of this pilot, and if all goes well, I think it will be adopted as a national health system by schools, hopefully.
Thank you, Professor Yazan. I have last question for Dr. Saif. You are working in Saudi Arabia, country where I worked some years there. Is there actually any system to screen all the kids for myopia or any refractive errors? And you were talking also about awareness. I have very genuine, simple question. How do you explain to the parents, to the society, to the people around, to the teachers, the benefit of an outdoor activity without calling physiopathology and complex explanation? How do you explain that outdoor activity is beneficial for the kids and why? So we don't understand as a parents or as a non-doctors or non-eye professionals. How do you explain, how you make it easy for awareness for the families?
Yes, thank you for this nice questions. Yes, here in Saudi Arabia, there is annual there is annual vision examinations for the children. When the child entering the school, there is a screening for the children by the teacher. After that, they send the children to the hospital. Like here I'm working in Qasim region, they send most of the kids to Qasim University hospital. The child undergo full eye examinations. And also in Qasim University, we have annual yes, a campaign for the vision screening for the children in many school. And also the university have an annual campaign for the community. This include comprehensive eye examinations for kids and for community, like for going to remote area, like area not in the city, far area. During the campaign, there is some doctor, they do some campaigning to raising awareness about the uncorrected refractive error and the effect of this untreated condition. Yes, here the community commonly believe on eye care professional or believe on the doctor. If the doctor tell them anything, they take this yes seriously. Commonly, we tell our students or in general to try to raise the awareness about uncorrected refractive or myopia, hyperopia, or any condition for the community. The community directly take this message seriously, but rising awareness need high level, maybe at the community level, and also for public media, for example, in TV, in radio. Should be some campaign in some interactive program, the leader, the figure, the religion, in the figure of religion in country, the public figure can also help in yes in raising awareness about control of uncorrected refractive error.
Thank you, Dr. Saif. Uh, I asked this question because in the Middle East, I used to have very often in my clinic patient family who comes for the second or third opinion because one of our colleagues said that the child needs glasses. Announcing that the child needs glasses in this area is sometimes felt from the family like a serious disease. So I don't know how you behave with this family to tell them that it is their benefit and to wear the glasses. I mean, we are facing this situation sometimes. I will not monopolize the discussion because I'm sure that there are many questions from the audience.
Yeah. Yes, doctor. There are a few questions from chat. Saidan, can you please address them?
All right. Hi. First, thank you, speakers, for those wonderful talks. Very crisp, neat, and so much information shared. And Dr. Nizar, you've asked, I think, almost most of the questions from the
Most
chat
of the
box.
questions are answered.
Very beautifully covered so that the speakers can explain in detail. I'm not going to take much time because in view of our next part of the program. So just one question, probably relevant more to the myocare, to Dr. Peter. There was one about how will the parents know if the child is adapting to the glasses or no? So if you can.
Thank you, Irene, for the question.
You're not audible?
Yeah.
Do you hear me?
Yes, now, yes.
Cool. So again, thank you, Irene, for the question. So from what I learned from the eye care professionals I personally met is that the kids are simply complaining. Yeah, that they are simply, behaving and speaking their words, so you will basically find
Being
out.
children.
So they are complaining about the glare, the halos, and basically feeling a discomfort.
So it's basically from what the child feels, like the feedback from the child.
It's also all the numbers basically I shared are based on a subjective questionnaire, right? So this is basically not like objectively detected. Everything is subjectively captured. Yeah. So it's basically just upon a discussion with the kid. Yeah.
Okay. And Dr. Saif, I completely agree with you about creating the awareness. It's not just the patients here, we are dealing with parents, the main people who are involved, where we need to take care of the progression of myopia. So creating awareness among parents is so important. The means you inform, like the social media or health campaigns, very, very important. And Dr. Yazan, that was very nice about the epidemiology, which is usually a boring topic. And I'm intrigued, in fact, to do a prevalence study here in UAE. So thank you, speakers. And Kani, you can take over.
Yeah, thank you, Irene. And to speakers, we would like to have a take-home message for the new practitioners and for the existing practitioner. We would like to work with the myopia control clinic. Can I ask Dr. Yazan to start, please?
Repeat, I didn't understand.
Yes.
I
Yes,
didn't
Dr. Yazan?
understand. Can you repeat?
No,
I didn't understand.
a take-home message.
A take-home message for the practitioners. If you want to prescribe myopia control lenses, I would encourage you to use cycloplegic diffraction, as it will remove all the accommodation effect and will show the truth of the refractive error of the patient. And please follow up every 6 months or as per the protocol that you would use. And for me, ophthalmic lenses for myopia management is a very safe and within the scope of our practice in the region. So, and it's showing very good efficacy. So just go with it. And thank you so much.
Thank you, Dr. Yazan. Dr. Peter? We can't hear you.
Can you hear me?
Yes, now.
Okay, perfect. So for me, it would be screening, screening, screening. At the second point, education, education, education. What is myopia about? What it can lead to? And at the third pillar, prescribe. And follow up, of course, as Yazan said.
Sure. Thank you, Dr. Peter. Dr. Saif?
For me, for eye care professional or eye care practitioner, try to increase the awareness of public and community about the options that are available for control of myopia. Tell the parent, tell the community, myopia now classified as a disease, not as the refractive conditions. Try the awareness about the complications of myopia, about the complication of high myopia, and about the disease related to high myopia, and try to raise the awareness about this complication could lead parents to try to seek for early treatment and control of childhood myopia.
Okay. Thank you, Dr. Saif. Ms. Celine, we would love to hear your thoughts on the webinar.
It was an amazing webinar. I mean, I learned so much tonight. And of course, I want to thank you, all of you. I want to thank you, Professor Nezar, as well, because you talked about all the subjects that I wanted to talk about. So definitely very perfect questions and very interesting talk, very interesting lectures. It's not the first time, and we are going to have, before the end of the year, another session. And I definitely can see how we are going more and more deep dive into myopia management. We started about 2 years ago now to have this type of educational program. And really, I can say that the level and the interest into myopia management as a practitioner and as a parent is increasing. And so I'm very happy to see that it's coming finally. I would like also to say, and I think that Dr. Saif's talk was really interesting about the awareness and the challenge here to talk about myopia to parents. We have launched, I don't know if you saw it, but I mean, I hope so. Otherwise, it hasn't worked well. But we did a big myopia awareness campaign since 2 months, 3 months on all social media in UAE, in Saudi, and different countries. And I really hope that parents understand now that they have to do screenings for their children. This is the first thing to do. So as ZEISS, we are also investing not only to support you in your daily practice, but also for the parents to understand the importance of going to screenings for their children and to do the follow-up after that. So this being said, we had an amazing audience tonight. I want to thank all the people, and I know that many of them has been waiting in the waiting room because we had a huge audience. So thank you for being more and more at each session. Thank you, the speakers, to take on your time to spend one evening all together to speak about a real concern and to share your best practice. So really big applause to everyone, and of course UOF is always there when we need education. Thank you, everyone.
Thank you.
Thank you, Celine.
Have a good evening.
Thank you, speakers, for your time and valuable insights and on myopia. Thank you, Dr. Nisa, for leading the panel. Thank you, Ms. Irene, for your valuable presence and insightful participation in the panel discussion. Now it's time for quiz. Let's have the quiz. Please scan the QR code and the link will be shared. Okay, you can scan the QR code. There'll be 25 questions and this has to be answered in 30 minutes. And you can also check on the chat box. A link will be shared. Click on the link where the quiz page will be opened. The first 15 winners will have a complimentary registration to October 6, which will be held on October 24th and 25th. Okay, so you're into the session. Thank you, Zeiss, for the wonderful webinar on the latest myopia reviews. Thank you for your continued support and expertise in myopia management, helping us to stay at the forefront of innovations. And now I would like to hand over to Mr. Ian for vote of thanks. Thank you all again.
Yes, thanks very much indeed, Devakani. It's certainly been an informative session, and I would like to thank all of our speakers for bringing their wide range and depth of expertise. And on behalf of the United Optometrists Forum, I would like to thank all the attendees, and I hope that the information imparted tonight gives you, enhances your understanding and management in cases of progressive myopia. Now I'd like to hand over to the President of the United Optometrists Forum, Mr. Swarna Kamal, and he's going to wrap up this evening's session. Over to you, Swarna.
Ladies and gentlemen, dear colleagues and guests, as we come to the close of this insightful webinar, I want to sincerely thank each one of you for joining us today. We are delighted to share that over 800 participants registered for this session, a true reflection of our collective commitment to tackling the rising challenges of childhood myopia in the Middle East and Africa, and of course all over the globe. Your active participation, questions and engagement made this session truly meaningful. Your CME certificates will be sent to your registered email ID within 21 working days. This is accredited by Dubai Health Authority with 1.75 CME credits. Before we conclude, I am thrilled to announce October 6, our premier optometry branded conference and the sole dedicated optometry event in UAE. Scheduled on 24th to 25th October 2025 in celebration of World Sight Day. October 6, much more than a conference. It is a movement to strengthen and to celebrate optometry in our region and globally, of course. There are so many exciting sessions. Cutting a scientific session with global regional experts, MyAbot launch, Optoverse Premier League quiz contest, which is very unique, and Optoverse Championship in after each and every session, engaging debate session, recognition through the Optometrist Award and Young Optometrist Award, which we recently introduced this year, and many more interactive and inspiring experiences. This is an opportunity as an optometrist to actively support and advance our profession. If we do not champion our profession, so who will? I invite you all to register, participate, and this part of this journey. Thank you once again for your engagement and enthusiasm today. Your commitment to learning, collaboration, and raising awareness truly makes a difference in combating childhood myopia and advancing optometry across the region and globally. With that, we officially close this session. Stay inspired, stay committed, and we look forward to welcome you at October 6 in October 2025. See you there. Goodbye.